So for the next part of today's talk, we'll turn to some pharmacology and discuss some drug interactions. So you don't need to memorize all the drug-drug interactions, but it's really important to be thinking about the potential for drug-drug interactions all of the time. So some of the HIV drugs will interact with each other, but also people will be taking many medications which will interact with their HIV drugs. So there's 4 categories of drug-drug interactions that we think about, all of which are relevant to antiretroviral therapy. We've got to think about over-the-counter medications. We've got to think about prescribed medications, recreational drugs, and then herbal medications as well. Then we need to think about, when it comes to drug-drug interactions, about relative versus absolute contraindications. Some things we may be able to get away with, but there may be some drug-drug interactions which are absolute contraindications. There is a fantastic web-based resource to look up with your patient, and it's called the Liverpool Drug-Drug Interaction Database. And the case studies you'll do after this online module, you can work through some potential drug-drug interactions and familiarise yourself with the Liverpool Drug-Drug Interaction Database. It's also worth looking up and sharing with your patient. There's a telephone app that you can download where you can actually quickly check potential drug-drug interactions also. So the main classes of HIV drugs associated with drug-drug interactions are the protease inhibitors and cobicistat, the booster, the integrase inhibitors, the newer form of tenofovir alafenamide, but not as big an issue with the older form of tenofovir TDF. The NNRTIs can cause drug-drug interactions, and the CCR5 inhibitor called Maraviroc, which we very uncommonly use these days, can also cause drug interactions. Most important drug interactions occur via the CYP P450 liver enzyme system. So in terms of the mechanism of drug-drug interactions with the PIs, the NNRTIs and cobicistat, it's via the liver enzyme, the CYP P450 system. These are a series of liver enzymes responsible for metabolism of multiple drugs. I won't go through this slide again, it's here for your reference, but worth looking at so that you understand the mechanism of the potential drug-drug interactions. Again, this is included as a reference slide so you understand the difference between P450 enzyme inhibitors and inducers and common examples of those. So ritonavir and cobicistat, so they're both pharmacokinetic enhancers. So all the protease inhibitors are substrates and they're metabolized by the CYP P450 enzymes. So ritonavir is a potent inhibitor of this system, the CYP P450 system. So it prolongs exposure of other protease inhibitors when it's given together with them. And we exploit that therapeutically. So we boost our protease inhibitors with either ritonavir or cobicistat. We'll talk about it shortly. But it prolongs the exposure of the protease inhibitor by being given with it, but it also prolongs exposure of many other drugs as well. Cobicistat boosting of protease inhibitors is also utilised in a similar way, as well as COBI boosting of elvitegravir, the integrase inhibitor that's contained in Genvoya, and it does that in the same way. This slide just shows you the role of boosting with ritonavir. So in blue down the bottom, you can see what drug concentrations could be achieved if a protease inhibitor was given but was not boosted. And what you can see is the dotted line through there, the appropriate drug concentration is not achieved through the life of the drug. When you give a boosted protease inhibitor, however, you can see the black line higher up is entirely above the level required to overcome resistant virus, but largely below that associated with PI toxicity. So this explains why we use boosters to boost protease inhibitors. So ritonavir is a potent CYP P450 inhibitor and has many clinically significant drug interactions. There are multiple classes of drugs affected, so it can boost some statins, some benzodiazepines, some calcium channel blockers, rifampicin, the erectile dysfunction agents such as sildenafil and tadalafil, some of the newer direct-acting oral anticoagulants such as apixaban and rivaroxaban, the Hep C, hepatitis C protease inhibitors, some of the oral contraceptive agents, and inhaled corticosteroids. Jump onto the website. It's worth familiarising yourself not only with the drug interaction tables, which can be found under the treatment selector section of the website, but also how to actually type in the individual's HIV regimen and then other medications which may be associated with drug-drug interaction. So comparing ritonavir and cobicistat, they're both inhibitors of the CYP450 enzyme system, but they're not the same. And it is worth looking up potential drug-drug interactions and how they may differ between those two agents. In addition to looking at the Liverpool website, chat to your friendly HIV pharmacist. They have an expertise that is absolutely invaluable, and so it is worth getting to know in the area you work your local HIV pharmacist. So some important interactions when it comes to integrase inhibitors. So L-bictegravir is boosted by cobicistat, so that's in Genvoya. We talked about Cobi being similar to ritonavir, and so the interactions are similar there. Bictegravir, dolutegravir, and raltegravir are all metabolized by the UGT1A1 pathway, and rifampicin is a potent inducer of this pathway and therefore can reduce the levels of bictegravir, dolutegravir, and raltegravir. So if you need to treat someone with tuberculosis, these drug-drug interactions need to be considered. Dolutegravir and metformin. So dolutegravir increases levels of metformin by reducing its excretion in the proximal convoluted tubules. So it may require a dose reduction of metformin. That effect is thought to be less with bictegravir. And then, of course, we talked about earlier that the drugs containing polyvalent cations, so metallic ion salts like calcium, magnesium, etc., can bind to and impair the absorption of integrase inhibitors. So you need to dose those medications either 2 hours before or 6 hours after the antiretroviral therapy. To be safe, I simply advise people to take them 12 hours apart if they can, or to avoid them. TAF does have some significant drug interactions, and it's different from TDF, the older form of tenofovir. So those drug interactions are mediated both by the cytochrome P450 and the polymerase glycoprotein system. Therefore, usual co-administered drugs are the culprits. In terms of the CYP450 inhibition, if they're taken with inhibitors such as cobicistat, or ritonavir, then you need the lower dose of TAF, so the 10 milligram formulation. When TAF, so I've explained that. But if TAF is taken in a regimen where there is no booster, then the higher concentration TAF should be used, the 25 milligram formulation. There are a number of medications which induce the cytochrome P450 system and result in induction of and therefore reduced concentration of TAF. These drugs called include, I should say, the anticonvulsants and some of the TB drugs we alluded to earlier. So if an individual is on any of these medications or needs tuberculosis treatment, then you need to consider initiating or switching them off TAF-containing regimens to regimens that contain TDF. And again, I can't emphasise the value of liaising with an HIV specialist pharmacist, as well as looking at the Liverpool drug-drug interaction website. Now, there are other drug interactions, so we need to consider over-the-counter medications, recreational drug interactions, and interactions with herbal medications. So if we're looking at over-the-counter medications, we need to be thinking about things we can get like some of the proton pump inhibitors or antacids, and they can interact with and reduce the absorption of atazanavir and rilpivirine by reducing acid within the gut, and the pH changes are then associated with reduced absorption of those drugs. Ritonavir and cobicistat, particularly ritonavir, is known to boost crystal methamphetamine, so you can get increased crystal toxicity and increased risk of crystal methamphetamine overdose with that combination. St. John's wort is an enzyme inducer, and it's known to induce protease inhibitors and the integrase inhibitors as well, and so it can reduce the concentrations of those medications and needs to be avoided. This, again, is the Liverpool Drug-Drug Interaction website, and I strongly recommend that you pause the video and have a really good look around this. There's some cases in the appendix that we won't go through today, which walk you through some of the common drug-drug interactions. And again, it's worth jumping on this website, also downloading it to your phone to share with your patients and working your way through some of those common and clinically significant drug-drug interactions. So the final topic of today's talk is, we'll briefly touch on resistance. So most people, when they acquire HIV, acquire what we call a wild-type strain of HIV, which is a naturally occurring strain of HIV without mutations. And so what that means is that there's no resistance, or the virus is not resistant to any medications, and so that individual can essentially start any of the medications recommended. Transmitted drug resistance can occur, so an individual may acquire virus from someone who has resistance, and when they have their baseline resistance test done, unfortunately, a small proportion in the order of 3 to 6% will actually have some resistance at baseline. So that's called transmitted drug resistance. The other way that resistance can occur is what we call acquired drug resistance. So when people are not taking their medication very well, they're missing doses, they're stopping, they're starting, or their drugs are not being very well absorbed, whether that's because there's a problem with the gut or a drug-drug interaction, as we've previously discussed, they may not be getting drug on board to treat HIV, or inadequate drug concentration. And so we can get resistance mutations developing under selected drug pressure, and that's a far more common scenario compared to transmitted resistance. So resistance, as I've said, is a consequence of insufficiently potent regimens. So in the old days, before we had the technology to perform resistance genotype testing, and early in the days of HIV treatment, we treated people with initially monotherapy and dual therapy, and then even the early triple therapy regimens were of lower potency, and unfortunately the early HIV treatments have caused some of the resistance. We didn't know that at the time, but it's important to consider an individual's treatment history if they're heavily treatment experienced and they need to switch regimens. Poor adherence, as I said, is the other common reason why an individual living with HIV will develop resistance. Resistance has been reported with every drug class. For some resistance, drug resistance, only a single codon change is required, but for higher barrier resistance drugs, such as the protease inhibitors or the newer integrase inhibitors, multiple mutations are required. When we see some resistance mutations, it can cause what we call cross-class resistance. So you can get resistance to a number of drugs within a drug class. So resistance testing is now standard of care. And what are we doing in an HIV resistance genotype test? So we're sequencing the genetic code of the HIV and looking for known mutations in that genome associated with drug resistance. So when we order that test, usually we just get resistance mutations for reverse transcriptase and protease. So that gives us information about resistance to the NRTIs, the NNRTIs and the protease inhibitors. But we don't, it's not standard of care to test for integrase resistance in Australia at this stage because we see so little of it, or fusion inhibitor resistance because we rarely use fusion inhibitors at this time. In order to perform resistance testing, we generally need a viral load greater than 1,000 copies per mil. There is now technology to do what we call proviral DNA resistance testing. So if an individual has an undetectable viral load, we can actually perform a resistance genotype. It's not thought to be as sensitive as a genotype that's performed on cell-free virus. So when we perform a resistance genotype on RNA, and the viral load is greater than 1,000 copies per mil, that is far more sensitive at detecting resistance mutations than performing proviral resistance testing. So there's limited clinical scenarios where you might organise a proviral DNA resistance test, and that's one where you might discuss it with your reference laboratory or an experienced colleague. If an individual has drug resistance mutations, but they stop their medications, and when you perform that test and your viral load that's done is greater than 4 to 6 weeks after stopping the medications, any previous resistance mutations that they might have had documented may not be seen. So those resistance mutations are said to be archived, and the resistance genotype appears to be a wild-type genotype. But it's important to ensure then that you look for all genotypes. So that individual might have had 3 or 4 genotypes done historically, and it's important to look at all of the genotypes, not just the most recent one where the where the resistance may be archived, because you may initiate them on a newer regimen and they might fail because you've missed archive resistance. And so when you're looking at building a new regimen for a treatment experienced person, it's always important to use the Stanford database, which is a resistance genotype database, to plug in all of the resistance mutations that come up on all genotypes that have ever been performed to check their current resistance genotype. Talk to your expert when you're trying to build a regimen, or talk to your mentor when you're trying to build a regimen for someone who's heavily treatment experienced. So just a little bit of nomenclature about resistance mutations. So the mutations are designated by the wild-type amino acid, the position within the sequence, and then the Newton amino acid. So the M184 mutation, which is a common RT resistance mutation, would mean that methionine at position 184 in the reverse transcriptase is replaced by valine. So that's just where the nomenclature comes from. When do we order a resistance genotype? Straight away, as soon as somebody is diagnosed, earlier is better. If someone has ongoing viral replication, despite the fact that they tell you they're taking treatment, we call that virological failure, and we want to organise a resistance genotype then, and to tell the laboratory what regimen they are on when they're failing therapy. In the context of pregnancy and when they're about to initiate therapy, it's important to arrange a resistance genotype. If they have an unclear or complex treatment history where they have an undetectable viral load and you need to make a change to the regimen because of side effects or toxicity, you could, as I said a minute ago, consider a proviral DNA resistance genotype. But that's one where you might want to talk to your mentor and have a discussion with your reference laboratory who will be conducting the resistance test for you. Again, a couple of important references I draw your attention to here. These are the HIV management guidelines for Australia, the ASHN guidelines, and these are the American guidelines, the DHHS guidelines, which Australia follows. Unfortunately, I can't answer any of your questions, but again, I urge you to pause, and if you have any, type them into the discussion board, and the course facilitator can answer your questions on that discussion board. And finally, I'm not going to talk you through the appendices, but in the appendices, there's some older drugs which are still available on the PBS, but are now infrequently used. Important to have a read through that information because you may come across patients who, for whatever reason, are still taking some of those older medications. And then there's also a number of case studies which nicely highlight some common drug-drug interactions. And again, I reiterate the value of jumping on the Liverpool Drug-Drug Interaction website, typing in the HIV medications and typing in the other medications, and then reading about the evidence and the nature of the drug-drug interactions. Really, I think practice makes perfect, as they say, and it's worth jumping on and understanding how those invaluable tools actually work. So thank you for your time. I hope you've enjoyed today's session and enjoy the rest of the course. Thank you.